Hi, everyone, and welcome to our medical student roundtable, Prepárate for HIV Care. Thank you so much for joining us, the National Hispanic Medical Association, and dedicating your time with us today. My name is Madeline, and I'm a senior program coordinator here at NHMA, and I also lead our CDC Let's Stop Together HIV campaign. The NHMA is a medical association representing the interests of Hispanic physicians across the U.S. Our mission is to empower physicians and other healthcare professionals to lead efforts to improve the health of Hispanics and other underserved communities. We are partnered with the CDC Let's Stop Together campaign. It's a national campaign dedicated to ending the epidemic and is an initiative of the National HIV/AIDS strategy. Our goal is to educate healthcare providers on resources and tools to provide best cares on addressing HIV. Just a few housekeeping rules. So in the beginning, all participants' microphones will be muted, but please feel free to raise your hand and ask the questions, or you can also type a question in the Q&A box and it'll be addressed to the panelists. We encourage everyone to engage in this conversation. And then additionally, the slides will be recorded. It will be recorded and we'll be it'll be housed on the NHMA website. So I'll turn over to our panelists today. We are joined by Dr. Jose Rodriguez Garcia and then Dr. Jorge Ramayo. So Dr. Jose Rodriguez, please feel free to introduce yourself.
Hello, I'm Dr. Rodriguez. I'm board certified family medicine doctor. I'm also an HIV specialist. I'm the current medical director at Spectrum Medical here in Phoenix, Arizona. Our clinic is a primary care clinic that focuses on HIV treatment prevention, also STI treatment and prevention, and LGBTQ plus care. So our goal is to create a safe environment for everyone, regardless of your gender identity or sexual orientation. And then I'll turn it to Dr. Ramayo.
Thank you, Jose. So hi, everyone. My name is Jorge Ramayo. I am an internal medicine and pediatrics physician. I'm also an HIV specialist. I work in Northern Virginia, where I am the medical director for the Innova Pride Clinic, which is the first LGBTQ plus healthcare clinic in Northern Virginia. Very similar to Spectrum Medical, it seems we do a lot of the same type of care in which our focus is to provide primary care with an LGBTQ plus healthcare lens, in which we do everything that is needed for this population, including gender affirming care, HIV primary care. We also do just general high quality primary care and lots of STI testing and of course, pre-exposure prophylaxis for HIV. So excited to be here with you.
Perfect, thank you. So I'll go ahead and start the panel discussion. Again, so the roundtable is going to be a really informal event. So we're not going to be focused on presentations, but more just the questions to get to know our physicians joining us today and their advice through getting through medical school, but also kind of just the general of the communication skills necessary when it comes to talking about sexual health preventions in diverse communities. So the first question, and I'll keep the same going, so with Dr. Rodriguez first and then Dr. Ramayo after, is what influenced you guys to be physicians who provide HIV care?
So for me, first during medical school, I was more focused on doing primary care. So family medicine was my choice because I wanted to treat the whole family and everyone in there, right? Being the doctor for that person. And then during residency, my first year, that's where I had my first encounter with someone who was HIV positive. And of course, my scientific background came there, and it was such an interesting disease. But also knowing that, simple to ending the HIV epidemic is just, having people on treatment and that just that will end the HIV epidemic. But when you bring into the social determinant of health, then that's where all the intrigue came into me. And that's when I decided to also pursue HIV specialization, but again, focusing on that primary care component and on their social determinant of health. So after that, that's where I started doing all my training for that, also for HIV and family medicine. And once I got out of residency, I've been practicing both, so doing primary and HIV, and it's something that has been wonderful for me and for my career. All right, Dr. Ramayo.
Sure. So was it very similarly, actually? I was, as a member of the LGBTQ plus community, it was very evident for me that there were a lot of health disparities within this population. And one of them was a very salient one was HIV and how disproportionately this population is affected by it. So I think that was one of the big impetus for me to think about HIV care as just a part of holistic primary care, which is what I was initially attracted to when I started medical school and continued throughout residency. I think that being able to provide that holistic care in a safe space for members of this community was so important. When I started my first job as an attending, I was working for a federally qualified health center in Milwaukee, Wisconsin, which was surprisingly very Latinx heavy. So I had a lot of Mexican and Puerto Rican patients, and I realized that this also affects so many of populations of color, but in a more intimate sense. I was able to actually see what this looked like in the ground, right? So I eventually became an HIV provider because of the great need that we saw, and eventually took over as medical director for our HIV program there, and that really taught me the ins and outs of like what it means to really care for this population in a holistic way. So in many respects, my career kind of led me down that path, but it was something that was always on the background, and you can always see how HIV is such a big component of the training and the care that we provide, and also the many lessons we've learned from patients living with HIV.
Perfect, thank you. You guys both mentioned how during residency these kind of shaped you, but is there a specific rotation that you found beneficial or that influenced shaping your medical career?
So during medical school, I don't think I had that intrigue on HIV, or it was more of family medicine. So I was more focused on doing those rotations. It was more during residency, but now looking back, and if I'd have known about that, a lot of health system, academic hospitals, they do have an LGBTQ plus clinic, and most of them also do offer the HIV treatment and prevention because it's kind of linked into it. So if it's something that you're interested in, focusing on that. Doing infectious disease also can help a little bit. Some of the programs do have that rotation for HIV clinic, but if you do mostly inpatient, depending on where you're at, you're not going to be exposed that much to to people living with HIV. So looking back, I would have definitely gone more into going into those county clinics usually have those programs also. So it's something that if you're interested is looking into that and, talking to your counselor about it.
I will say that, during residency, as I mentioned, I did both internal medicine and peds. So for internal medicine, you have the benefit of being able to rotate with the ID specialists, and they are the ones that tend to actually see a lot of these cases. So that was very eye-opening, and that allowed me to actually have some mentorship from other Latino clinicians that were doing this type of work, and just seeing what they were doing, seeing what their clinics look like, and just being inspired by like what type of work they were doing and how much effect they were having in the community was really one of the first things that kind of set me on this path. So I think regardless of that, I think I was able to find some other mentors in different rotations, just kind of keeping your eyes and ears open to like people that are doing inspiring work that you strive to eventually do is something that's very useful. And the mentorship piece was really key.
Thank you. And then what have been both of your experience as Latino physicians in the field of HIV? What have you experienced?
So for me, there have been positive things on that. One of them, it's a lot of people going in to seeing me, and because I'm Spanish is my first language. When I start speaking to them in Spanish, their eyes just open, and they're like, "Wow, you speak Spanish. You're an HIV provider. You're going to be my primary care doctor." Is just really eye-opening for them. And of course, the report buildup is just goes high, and it's really easy to talk to the patient or for them to express what they're feeling, because it's really hard to express, especially in HIV care, and even another language, or the cultural barriers. Even if you have interpreter there. It's still that barrier that, they're trying to express something, especially sexual health, and it's really hard for them to do it. But once they have someone that they identified as, it's really easy for them. They're more open, and they want to ask more questions. They want to bring down that stigma of HIV, and you're the one that is helping for that. So yeah, being a Latino physician, and especially in HIV care, we don't have that many. So it's something that, benefits everyone. And since, especially here in Phoenix, HIV incidence is the highest amongst Latinos MSM. So having that HIV provider there, it's something wonderful.
I agree, and I think I experienced something very similar, right? You're able to have this buy-in from your community. When you walk in and you look like them, you speak their language, you're able to actually break down those barriers and be able to use that. I always tell my medical students and residents, like, use that to your advantage, get all the points buy-in, because sometimes these can be labeled as difficult patients that are not necessarily following what the recommendations are from the other clinicians. And in reality, there's a lot of misunderstandings and miscommunication that happens. So I just see this as an opportunity, as a privilege, right? So you're in a position of power and privilege to be able to provide this care to this community that really needs you. So I just, not only is it like a great experience for the patient, it's a great experience for me, because I actually feel a sense of fulfillment after that visit and being able to know that I was able to make a difference for each patient. So that's been my experience treating HIV patients.
Thank you. And then what advice do you guys have for the next generations of physicians that are entering this field or considering entering, becoming HIV specialized?
Yeah, so especially if you're interested in primary care, doing pediatrics, OB-GYN, family medicine, internal medicine, anything that you're the primary care contact of that person or those patients, you should know about HIV care. HIV medicine is easy. The medical management, it's easy. It's easier than diabetes and hypertension. So if you're able to manage that, you can manage HIV care. But definitely it's knowing how to talk to your patient, getting especially that sexual health history, getting those. So if you're interested in that, even if you're not going to do HIV like, Dr. Ramaya and I'm doing, but still having that tool. So whenever you have a patient who's HIV positive, you're able to provide that care. And if you're not able to provide it, then, you're able to refer. But 95% of people living with HIV, any primary care doctor should be able to manage their HIV care.
Yeah, for trainees interested in this, I think there's different layers, right? So first is that you do not have to be an ID specialist to be able to treat HIV. That's something that is actually fairly new. The treatment options we have are so modern and so effective and so simple that for most of my patients with HIV, their HIV is the least of their problems. Their problems are truly their diabetes, their hypertension, everything else, their psychosocial stressors that are affecting their health. So I think like the HIV becomes like a secondary piece of everything, and just being able to address that plus everything else that goes into primary care is so key. Again, you don't have to be a specialist. If you want to be a specialist, I don't want to dissuade anyone from like thinking about infectious diseases. It's a very nice and fulfilling role, and you can still make a lot of a great impact with that specialty. I feel that even if you go into other specialties and that may not be necessarily related so closely to HIV or primary care, at least knowing some basic concepts about how to treat people with HIV, reducing the stigma, things and concepts like U equals U, which is undetectable equals untransmittable, making sure that you know the tools to prevent HIV transmission, like PrEP, especially for somebody saying going into OBGYN, like that's something that is actually very underutilized for pregnant patients. Things like that. There's so much overlap with so many different specialties that it definitely behooves you to be very well aware of what HIV care looks like now in 2024. But I would say if that is even a small interest that you might have, it's something that is badly needed. So we really need more of us to treat our communities. So I highly encourage you to pursue that if that is an interest of yours.
Thank you. And then looking back, is there anything that you both wish you knew sooner, to prepare you for residency and beyond while you were in medical school?
Probably for me, yeah, knowing that as a primary care doctor, as family doctor, you were able to do HIV medicine, because in the past, I thought it was just infectious disease doctors that were able to treat. And I didn't want to specialize. I wanted to be that first point of contact. So knowing that was something, if I'd have known sooner, should have gotten more experience. That, and also for hepatitis C treatment, as they're linked together. In the past, it's like, oh, you have to be in GI doctor to treat or ID, and now that's not the case. Now, as a primary care doctor, now we even have nurse practitioners, PAs that are doing that for us, because it is simple. Treatment options are simple and side effects are minimal. So it was just knowing that. So, it's in medical school, you have so many roads to go, and the only road that you're seeing, it's the one that it's laid down there to you. So just try to be more open-minded, ask questions like this roundtables. It's an opportunity for you to know what's out there and how things are changing, the landscapes that are changing. And HIV is one of those that is going to be a primary care chronic medical disease managed by primary care doctors.
I love that. I'll just be a little bit more broad. I think that just being able to be creative and thinking outside the box about your professional aspirations and careers is also something that I think when we come from medical school, everybody does classes, then they go to residency, then they get an academic job, then you're supposed to publish papers, and that's the only way to be a doctor. And that's not necessarily true, right? So there's many different creative ways in which you can actually take your skills and your talents and be able to actually create a larger impact for your community that does not necessarily involve only clinical care. And that's one of the things that became clear to me as I continued to, move through the ranks and graduate. And just initially, I started just as 100% just clinical physician that was just seeing patients, and that was it. That was going home. But like thinking broadly about like what is a passion of mine, what else can I do as a physician to be able to affect change in the community, was something that was I found through my mentors and like people that I admire that are doing this type of work, and they're actually working on a broader scale to be able to just multiply the impact they have in the communities they serve. So I encourage you to definitely seek mentorship, cultivate those relationships, and then find what makes you happy and what actually you want to do with this wonderful degree of medicine.
Thank you. And was there a challenge that you can share that you faced during medical school that has also shaped you today?
I think one of the challenges is choosing the residency program. They're really hard. They're all good, but they're not all meant to be for you. So it's knowing that, how you see yourself practicing in the future, and try to tailor that down to the residency program you want, right? Because if, like for myself, I was never interested into academics, but if I would have stayed in an academic hospital where it's more teaching, or you have other subspecialists, it's just big hospitals, you do see really rare cases, but at the end of the day, it's like, is that going to help me for my career? So I'm like, okay, I need more of a community hospital where I'm going to see more of the bread and butter, more of what really it's going to lead me into my profession. So I think it's just trying to have a broad idea of what you want in your career in the future, and try to help you that make the decision. But it is a hard decision choosing a residency program. I wish it was something simple. I chose the one that I thought was the best, and it was really amazing. But yeah, it's just something that, don't worry, but I think that's the best approach you can do it.
For me, I think, it goes back to that whole idea of imposter syndrome that many of us face. I think that whenever personally, I was facing any challenges, I remember clearly my ICU rotation, feeling totally overwhelmed, so much work to do, orders, notes, patients to see, and just seeing my colleagues around me just thriving, but like me having a hard time, and then just being like, oh, am I meant for this? Is this for me? And just pausing and giving yourself a little bit of grace and remembering that you are just as good as anybody else there. You might need to work a little hard, but you made it to where you are for a reason. Asking for help when you need it. Sometimes people are a little bit too proud or too shy to ask for assistance or help when they're actually struggling a little bit. So remembering that taking care of yourself is very, very important. Residency is a very difficult period of time for anybody. Training, it's going to be long hours. It's going to be a lot of mental and physical exhaustion. So just being ready for that and making sure you have your support systems to be able to maximize the quality time you have when you do have a time off, right? When we explain to friends not in medicine what a golden weekend is, meaning that you had both days off, wow, they're just like, what does that mean? You know, like that's not something that's normal. And just knowing that this is something that shall pass, right? It's almost like a rite of passage. People have to go through this training. It makes us better doctors at the end, but it is a very strenuous process. And sometimes people can struggle. That doesn't make you a bad person or a bad doctor, but it just means that you have to give yourself some grace and ask for help when you need it.
That was really beautifully said. I think to follow up with what Dr. Rodriguez mentioned about residency and kind of picking the right one, is there any advice that you have when it comes to choosing the right residency program that fits one's personal goals and cultures and what they're really looking for in the future?
Yeah, again, is trying to see where you want to be. Another good technique is asking about the alumni, where they're at right now, right? So people have been in that program where they're at and seeing if some of them match where you want to be. Because let's say you go into internal medicine and you want to become a hospitalist, and you see all the alumni have subspecialty or they're going to subspecialty. So it's like, oh, this might not be the one that I want. Again, as just seen or intriguing because again, medicine is really broad. So every program focused differently of where they want their residents to be or what their strengths are. So I think that it's an advice that I have.
I would add to, I think with the way things have shaped since COVID, there's a lot of virtual interviewing that happens. And for that reason, you don't get the chance to go as much in person and talk to people one on one. And I think there's a gut feeling that comes after each interview that you have to really listen to because you want to witness what that culture of that residency program might look like, right? Because it may not be the right fit for you. I also encourage people to ask questions about like what are your DEI efforts, right? Diversity, equity, and inclusion. Like, is that something that's important to your residency? Have you talked about it? What does your different resident classes look like, right? Are you trying to be inclusive and making sure that your residents are reflecting the population your hospital serves? I think that will give you a really huge hint as to like the type of place and environment you might be walking into. It might be a top research institution, but if they are not going to value those things that are so important, then that might actually be a red flag for you. So thinking about that, I think is something that we often as people of color may not necessarily think about or put a high price to, but I think it can make a huge difference in the quality of the education you will be getting.
Good. Okay, and then we actually have a question in the Q&A, and it's how can we as prospective medical professionals seek mentorship opportunities and support system, especially as Latino students who don't know where to seek or find other Latino professionals?
So actually here, the NHMA do have like mentorship programs. I've been part of those. Depending also on where you live, like in Southern California, we have, oh my God, what was that organization name? Mi Mentor. I also participated as a mentor there. I think also Northern California now has it. So there's many organizations in that. There's a lot of Latinos chapters for medical students. Also, like for myself as a family doctor, we have the AAFP, the American Academy of Family Physicians. They also have a Latino chapter on that. So it's, sending that email and being that you want to connect to someone. When it's for HIV, we do have other organization, AAHIVM, and you can send an email there, and they're able to provide free training for you, during residency, outside of residency. If you've been in practice for 10, 20 years, and now you want to become an HIV specialist, they're able to help out. So it's just seeking those opportunities. And here's definitely one that, I'm happy to share my contact information. And even if, you're not here in Phoenix, somewhere else, but it's like, oh, I know someone that, can help you out, another Latino physician out there. So yes, we will definitely, share our contact information.
Likewise, I mean, I'm happy to as well. And I think there's different realms I like to think about this, like regionally, like do you have somebody that you can actually have that's in the region where you're working or you plan to be that's doing some of the work you admire and you like doing, right? And reaching out and just drafting a respectful good email and being like, hey, I'm interested in either shadowing you in clinic if that's an option. If you're involved in research projects, I'm looking to get involved. Things like that is something that sometimes, especially in academics, you can see different people being interested in and taking people over. Um, the other thing is nationally, like you were mentioning, Jose. So like there's so many different national organizations, and each one has a pipeline mentorship program, right? So if you're interested in orthopedics, there is a Latino Orthopedic Association, actually. If you're interested in dermatology, there is an interest group within dermatology or like a subset from the Dermatology Association. So seeking out those opportunities and seeing the commonalities you may have with the other person, because they have obviously the benefit of finding another Latino mentor is that they know your story and they have shared some of the struggles you're sharing. So like being able to be like, hey, how do I go about this? Like if something odd happens, having like that mentorship to kind of run things through is so key. I was able to find one of my mentors through my residency, and she is a family medicine clinician that's doing amazing work. She created a food pantry for like the west side of Chicago, and she was just so involved. But she was able to just tell me, hey, this is how the bureaucracy works here. This is what they're looking for. This is what you have to look out for. So have somebody that has your back and is able to look out for you, and knowing what your aspirations are and being able to guide you there is very, very important. But it takes work, right? So you have to be able to follow up, check in, keep up with those people. I think that's so important. So cultivate. I'm not gonna say like just a bunch of random mentorship relationships, but really a few that are like very key and critical to what your professional and personal aspirations might be. So yeah, again, reaching out to all those national organizations, regional organizations, and also within LMSA and NHMA, we have formal mentorship programs for that purpose as well.
Thank you. And another question is, can you both speak on any bump in the roads on your journey to become an HIV specialist and how you handle them?
There were many. There were many, many bumps on during training, and not just for HIV, but also for just becoming a physician here. But yeah, I think it's just finding those mentors and having someone that can support you and help you throughout that journey. Because you're gonna come into an obstacle, or you're gonna have, a challenge. And it's just knowing that, one, you're not alone, and two, if you have a mentor that has already been through that, then they're going to help you. It's like, if you do this, this is going to happen. Because especially the residency, it's a lot of time that you have to consume. So you're going to take that time off from family, from friends, and it does become difficult. So finding that balance, it's something hard. So whatever challenge do come, just to have that right person in there. Because like for myself, one that I had was an internship year, burnout. When we started residency, they're like, you're gonna have burnout in December and January because it just happened to 6 months after training. And I did not believe that. I'm like, no, this is not happening. This cannot happen to me. Like I think I'm good. And it did happen. It happened at the end of January, where I was going through the rotations. And I mean, it's just, you feel like a robot. You're not thinking, you're not doing anything. And it's like, okay, this is not normal. I need to reach out to someone. And I had my mentor there at our residency program. So I talked to him, and it's like, okay, this is happening. And of course, it's like, let's create a plan. Let's not take you out of rotation or anything, but let's make a plan for you to, overcome this burnout. And yeah, just a couple of days, we made some changes on my schedules. And after that, it was smooth transition throughout the whole residency program.
Yeah, burnout can absolutely be very real. I think in this stage, for a lot of the students that are like thinking about applying or in the process of applying, if there's a blemish in your record, you can definitely be very self-conscious about that. And if it's something a little bit more significant, I think it was for one of my steps that it was not the most ideal score that I had. And I was very concerned about what that would do for my chances of getting into the residency programs I wanted. But what I quickly learned is that it's not so much about what the number is. That number kind of gets you in the door, but then after that is about everything else, right? So when and if you have something that you have to explain, or something that may not make you the ideal applicant for whatever reason, being able to, first of all, clearly state this is what happened. This is why what was happening around that, not creating excuses, but providing context. And then finally being like, this is what I learned from this. This is how I learned that I'm resilient. This is how I learned that I need to do this. This is how I changed my study habits to do this. And this is what happened after. And being able to show the growth professionally, mentally that you have undergone because of challenges. This is another challenge, another obstacle that you've overcome. And I think people, program directors, everybody looks very positively at somebody that can self-reflect and be able to actually provide concrete evidence. This is something that happened and this is what I did about it. So just to encourage everybody that, like, you're not going to have the perfect record. Nobody does, truly. And then just being able to be the best applicant possible, it also makes you human and allows you to show that other aspect of yourself. So I think that's so key.
Thank you. And then there's another question. As you are treating HIV, if you notice any cultural barriers to treatment, such as stigma that exists around HIV?
HIV stigma, yes, a lot. We do have a program that is called the Rapid Start program here in Phoenix, which means someone who tests positive in the city of Phoenix for HIV, they're linked immediately the same day to our clinic or to any other clinic. So we get that person, let's say, you do your HIV test this morning, you're positive, we're seeing you in the afternoon. Every time we see someone, they're coming in crying, like it's a death sentence, like, oh, I'm just gonna die. And that first visit, we don't talk anything about medicine. We do start them on treatment, but it's just like, we're gonna start you with this pill and we'll talk about more. But through the whole 30-minute, 1 hour is talking about that stigma, that it's okay if you're HIV positive, you're not gonna die, that you can still have a healthy life, a healthy sexual life. You can continue doing all your activities. If you're interested in having a baby, you can have a baby. All those stigmas. And then especially in the Latino community, something that I've encountered more is that stigma of my family. What are they going to say? And unfortunately, there's still a lot of stigma around LGBTQ plus. So it's like I haven't even disclosed that I'm part of the LGBTQ plus community. So it's like, okay, let's formulate a plan. Let's try to bring that barrier down of stigma around yourself and around your family. So it's something that is still there. And I think as being that first point of contact or ordering that HIV test, and if someone is positive, is knowing how to break down or trying to bring down those stigmas.
I agree to what Dr. Rodriguez Garcia said. We have so much stigma even in 2024 that we're trying to work through. Obviously, a diagnosis of HIV is such a huge monumental moment in somebody's life. And I feel very fortunate to be able to be there and actually walk them through that, right? So being able to be like, it's going to be okay. This is going to be a safe place for you. This is where you, like, if things are happening, we have support, we have therapists, we have things that we can offer you. And also kind of like being able to understand the stigma that people may face outside of our clinic walls, right? So I have an example. I had a patient that came to me and they were not asking, they were demanding to be placed on the injectable HIV medication. And it was not an option. Like, we're trying to, like, be like, hey, okay, let's talk about this, like, what's going on. And this is where being curious, but also like having that rapport with the patient was very useful, right? So in Spanish, we're able to have the conversations like, why is it that you need that? And what happened was their neighbor had found, like, or like opened their mail or something, and they found their HIV medications, right? And now the secret was out and they were out. And it was such a huge deal and such a devastating thing for this person that they just didn't want that chance to happen again. So they wanted to switch to something that they don't have to be taking every day. They don't need to be hiding it. And that makes sense, right? But had I just been like, well, no, I'm the doctor and this is what it is, it wouldn't have gone that well. So that's why this was something that just kind of opened my eyes to, like, wow, there's so much stigma still present in our community that we have to be very mindful of when we're treating our patients.
Thank you. And then I guess, like, that is treating HIV, but kind of the preventative. How do you guys begin those conversations with patients that are coming in just for a regular yearly screening? And if they're at high risk, how do you introduce that topic of prevention to a patient that could be at high risk of HIV?
Yeah, so those are really good topics. And annual wellness visits, is talking about all general health, right? And sexual health, it's a big component. So every time I have medical students or residents rotating, I tell them sexual health is a big component and knowing how to ask those questions, okay? And bringing down that stigma first. How to do an HIV test. And actually, CDC recommends doing an opt-out testing, right? Just telling the patient that you're going to do an HIV test, like doing an A1C, a lipid panel. You don't explain too much why you're doing it. If they have questions, then you answer those questions, or if they decline, you don't do the test. But it's doing that because, again, you're kind of time limited, unfortunately, and as your career progresses, you're going to have less time to talk to people, to your patients. So it's having that, doing that test, and it's recommended, CDC recommends once in a lifetime, but depending on the area where you're at, especially here in Phoenix, where, we're one of the hotspots for HIV incidents, it's like, let's do it every year. We need to update your HIV status. And it's talking about that. And then, during the sexual history or sexual health history, it's telling that, not labeling anyone as high risk. Because if someone asks me what's the risk of having HIV acquisition, it's if you're having any type of sexual contact, you're at risk. Doesn't matter if it's just one sexual partner, because unfortunately, you don't know if you're the only sexual partner for that partner. So it's like, it's your health and given that empowerment of health. So it's like, let's do your HIV test. Let's update your HIV status. And if you're HIV negative, it doesn't stop there, right? Let's continue for you to be an HIV negative. And these are the tools that we have. And HIV PrEP is one of the amazing tools that, it's recommended to telling everyone that that tool exists. So even if it's like, oh, I don't need it right now, but in the future it can change. And it's like, oh, I know PrEP exists. So before engaging in more sexually risky behaviors, then I know PrEP exists. Let me go talk to my doctor so they can prescribe that. So it's just letting them know, and just, having that habit as talking to someone about weight loss, about eating, about, doing the DASH diet. If you start talking to that and during medical school, that's when you have the most time to talk to patients. So utilize that time. Take your time and just ask. And people will actually be open and will go ahead and answer all your questions.
I agree. I think that a lot of the time the tools for HIV prevention come from like taking a really great sexual health history that's comprehensive. And what I like to do is obviously set up the stage. I'm just like, hey, we're going to talk about sex, very sex positive, open-minded. I tell them this is the gay clinic. It's hard to shock me at this point. So just like, whatever you want to share, you're free to. And then I have a set of questions like sexual orientation, gender identity, what activities do you do? I actually even ask him about kinky play or things beyond that, so that I can make sure that we're like, looking out for safety if like there's some high risk sexual acts that they're, engaging with. What type of position and sex you have, so I know where to test you. So I give him a reason why I'm asking these questions, right? And then when was the last time you were tested? Do you have any STIs? Did you have any STIs before? All those things have a reason for me to ask that. But by being able to get a comprehensive sexual history, I'm not able to assess I'm able to assess the risk for HIV, which is one piece, and that's when PrEP becomes a really important piece of the discussion. But I'm also able to evaluate for other parts of their health, right? So if they're having issues with sexual function, for instance, is it something more like, are we having issues with, like your obesity or your diabetes? Is that affecting another aspect of your health, right? Because everybody's a sexual being, and like that is an important piece, especially for Latino men. Oh my goodness, it's so difficult for them to talk about this stuff. But once you are able to open the gates in the conversation, it's just like flows. And they're like, oh my gosh, this has been such a huge concern. I feel less, especially like cis men, it's like, I'm less of a man because of this, and this has been a big problem. But then they're so relieved that they can actually trust you and talk to you about these things. And it's like actually very rewarding to be able to get that information. Once you identify somebody that's actually at considerable high risk, especially in some of the MSM populations, that's when you can have. Do you know about PrEP? Do you know about DoxyPEP? Did you get your Mpox vaccine? Like all the basic things that if you are part of even if you don't consider yourself to be part of the community, if you're engaging in these types of acts and what we could consider to be risky, I just ask them, yeah, you're just being a sexual person in the world, but there is some risk associated with that. What can we do? Let's partner so we can decrease your risk, right? And I think the patients really take to that. And even if they're not ready for something like PrEP at that visit, at least they know about it now. And then the next time they come in, we're going to talk about it again and see if they're ready at that point. But I love the comprehensive sexual history. I think that's one of the key pieces that we're able to do that can give you way more than you think.
No, that's great. I think it's also really important to highlight like culture does matter. I think especially in the Latino community, since there is so much stigma still associated with having a positive HIV test. But it's also kind of in those patients, for instance, for women who sometimes tend to be a little bit more reserved in terms of talking about their sexual history, and also provide like prescribing PrEP to them. Is there like any recommendations you might give into kind of in the cultural matter addressing that hurdle with people that may not be at high risk, but it's still just good to have those conversations with?
Yeah, with cis women, especially in the Latino population, it's not harder to get the sexual history. It's just knowing them like, hey, we're gonna talk about this. Is it okay? Right? First, you always ask for the permission because you're asking about other social history like tobacco, alcohol, drugs, and they're like, okay. And then that's when you start engaging in those conversations and not just asking, are you sexually active? Yes, no. How many partners? This amount? Okay, good. No, you ask more. What type of sexual contact are you having? Or is your partner with other, having other sexual partners? And then they're like, well, actually, yes. Okay. Are you using any barriers? Because if that other partner has an STI, and then it can be transmitted to you. Well, no, I don't use any barriers or anything. Then it's like, okay, these are the tools that we have, PrEP and DoxyPEP and or PEP if you're not on PrEP. And it's just having those tools there and knowing that actually, like, especially here in Arizona, 30% of new HIV cases came from cis women. So the cases are high. And not just that, syphilis, congenital syphilis is extremely high. So they're all linking to that. So, it's having that opportunity and there's still that stigma, especially within the Latino community that, to contract or acquire HIV, you have to be MSM or you have to be gay. And it's like, no, it's not. Everyone has that risk and it's just sending that telling those the people that it's like, let's get tested and let's if you're HIV negative, let's continue being HIV negative.
Yeah, for cis women, I think it's definitely a matter of making sure that the screenings that you're doing are appropriate. So everybody should be getting screened for HIV, and that's something that's an opt-out, as you mentioned, Dr. Rodriguez. So that's very, very important because sometimes if you're having to give you an example, what happens with OBGYN cases when they go in for their prenatal visits, they will get a syphilis test. And sometimes those come back positive, which is a complete surprise to the poor patient, right? And that should give you a clue and to be like, okay, what's happening here? Do we need to have like a really in-depth conversation about like what else can we do to prevent this person? And sure enough, like sometimes it comes out like the person was very afraid to tell you they're a sex worker, or they do have multiple partners, but they just didn't feel comfortable telling anybody, right? So being able to act in those situations and being able to kindly and empathetically being able to gather a history to see if it's truly somebody that should be could utilize these tools is very, very important. That's the one clinic or instance in which I've seen like, wow, this is something that we should definitely be asking more about. But yeah, I agree. In general, even if you're a lower risk, if you're asking the questions in the right way and the patient trusts you, if it's somebody that actually should be on PrEP, they will reveal themselves. But it's a matter of asking the right questions at the right time.
And then how would you guys foster that safe space, especially if you're doing primary care visits and it seems so rushed, quickly answer yes or no questions, like how do you make sure that the person feels really safe enough to answer, you know, sensitive or intimate questions?
Yeah, the way I do it first in our own clinic, we have safe space, be yourself, all that, right? So just you walk in and you see all that, we create that environment, right? But even with patients, when I start asking about social history, drugs, sex, alcohol, tobacco, the first thing I tell them, this is confidential. This is just between me and you, because a lot of them, I'm their doctor of their partner. So it's like, oh, is he going to say something? It's like, no, whatever we talk, even if you're positive for gonorrhea, chlamydia, or anything, I cannot tell your partner, and I will never tell your partner about that. That's a whole different process, and it's not going to be coming from me. So it's just telling them that this is a safe space, confidential, nothing will come out unless they want to hurt themselves or they want to hurt someone else. That's the only legal way that I have to tell someone about that, so that you create that environment that it's like, okay, we're just going to talk about this. And then you ask for permission, even for tobacco, like, hey, do you give me permission to talk about that? And if they say yes, we do. If no, then no. Again, 99% of patients will say yes. It's really rare for someone to say no. And then having that open questions, right? You do say like, oh, how many sexual partners have you had, or yes or no, but more of, oh, tell me about your sexual activities. What sexual organs do you use? Do you use any toys? Any foreplay, any this, any different sexual partners at the same time, any things like that, and they're more descriptive, and you're getting the idea of, okay, what sexual organs they're using, what do I need to screen, what do I need to do, how do I need to counsel, because again, I've had an encounter a lot of patients that for them oral is not sex, right? And it's like, no, you can still get HIV transmission, you can still get gonorrhea, chlamydia, other STIs. So it's something important that, you can use barriers, you can do this other options or other tools to prevent that transmission. But it's just having that environment that, it's going to happen. And then if you see that that person, it's kind of guarded, it's okay. Stop the questions. Again, you're a primary care doctor, you're going to see them again. So it's like, oh, I'll see you in 3 months for your diabetes. We're going to talk about this again. Oh, okay. And they already know that in 3 months, you're going to bring up this topic again. So, and the same as with smoking counseling or cessation counseling, all that. It's the same tools using over and over, but now within the sexual history.
Yeah, no, I think that's textbook. That's great, Dr. Garcia. I mean, just creating that space is so important. I also tell them, like you can tell me as much or as little as you want, and that's okay. But it just helps me as your clinician to be able to counsel you and provide you with my advice, which is why you're here, with the more information I have. So yeah, whatever you want to share with me. So kind of leaving that option open to be like, maybe today's not the day, but you can talk to me about this, right? So again, about creating that safe space, just letting them know, hey, privacy is going to be reassured, except in those special cases. I think that usually drives the point that I'm here for you. We're partnering here, and I just want to make sure I know how to best help you. And for me to do that, I need to know what's going on, right?
Perfect. And I'll just ask one last question before we kind of end our great roundtable. And it's just if you both can share just one anecdote from your entire medical school residency doctor journey that you found very valuable and has put you where you are today. If there's just one anecdote that you could share. Take your time. I know it's asking a big question.
Do you have one? Because I'm still trying to think of
Yeah, I
one.
can share one. I mean, this is actually like a very telling one. So, it's the story of two patients, to be quite honest. It's like just it puts you in your face like how our system is so unequal, but just being thankful for being there. When I was in Milwaukee, I met this patient who was a young guy. He was gay. He was having sex with men. He was high risk. We talked, put him on prep. He was happy. He was on it. And then I didn't see him again. Right. So I didn't see him for maybe like a year. So almost on the date I saw him a year later. But it was some very unfortunate circumstances. He had run out of his prep. He had traveled somewhere else. He was a temporary worker, and he had contracted HIV. And that was one of the really sad cases that really brought it to just my office, like I'm in front of this patient who's devastated, who could have been this could have been prevented, right? And it was just a matter of like how, because of his social economic circumstances and everything else, despite my best efforts, we weren't able to continue his treatment to prevent HIV, and we now had a new case. And then that compared to, I had, this patient was Latino, poor, and all that. I had an affluent patient who, um, was young, and the parents had found out that he was gay, and the parents were so loving and concerned that they're like went above and beyond and went and found the only adolescent doctor that would actually prescribe PrEP in our area, which was me, and be like, my son is at risk of contracting HIV, and I need you to help us, please. I don't want him to get HIV. And because of the fact that this family had the resources, the means, the time to find me, they were able to get a like PrEP right away, and then we were able to likely prevent an HIV infection for somebody that was really, really high risk. But I see this as a story of like success on one side and a failure on another. And that's just a testament. It's like we have these tools, but we just need the systems to be able to implement them. And that just kind of reinforced my commitment to like, okay, we need to expand the access to these tools and these resources to everybody, regardless of who they are, so that we can continue to prevent more HIV cases in the future. So that's one of the reasons why I do what I do and why I love what I do. And I hope that that's the reason why I feel things like this are so important, to be able to increase the numbers of people that look like us that are providing this care.
Yeah, those are wonderful stories. And yeah, I think as an HIV provider, you always encounter those positive and negatives. For me, I think one that was kind of not an eye-opener, but kind of not as expected. Right after residency, I started working in Central California in a rural area. So mostly farm workers there. So one of my patients, she was around 65, 70, coming in for annual wellness and other medical conditions, during the sexual history is like, oh, I've been widowed for 6 years, so no sexual contact since then. And it's like, well, we're still going to do the HIV and STI screening. And she was like, oh, really? I'm like, when was the last time you had it? And she's like, oh, like 30 years ago with my last baby. It's like, hey, let's just go ahead and, run it. The insurance will pay for it. It's preventive, no issues. Okay. So actually her test came back positive for chlamydia. So it was like, okay, I brought her in. It was not just like a phone call, like, hey, you're positive, get treatment. It was like, no, I do need to talk to you. And it was more like, hey, you're positive for chlamydia. And she's like, how can that happen? It's like, well, most people are asymptomatic, unfortunately. And, you probably, if your last sexual contact was 5 years ago, then you've been carrying it since that time. Okay. So, let's not point fingers or anything like that. There's treatment. And then again, 3 months, we're going to get the test of cure, and that should be okay. And, again, and it also encourages them or telling them that, sexual contact is something positive. We're sexual beings. So if it happens in the future, it's better to have that prevention. So that way, if you do have a new sexual partner in the future, then that's okay. Because again, we think in geriatric medicine or people who are 65 and up, it's like, hey, they're not having any sex. Well, they're retired. They have nothing else to do. So most people do engage into more sexual activity than in their midlife. Okay. So it's just, again, the importance of testing everyone, because that's a missed opportunity for that.
Perfect. Thank you so much. So that would wrap up our medical student roundtable. I just want to say thank you so much for Dr. Rodriguez and Dr. Myers for sharing your time. And you guys are very busy as doctors, as you guys mentioned. So I really do appreciate you taking your time, sharing your experience, your insights to us and our medical students. And I also just want to share a few last things for our guests before I let you go and enjoy the rest of your day. So like always, we do partner with the CDC for the Let's Stop Together campaign. They do offer resources for clinicians, for patients, from a range from preventative treatment, care. You're always welcome to look at their website for more information. And then lastly, just a few upcoming events for NHMA. So we are celebrating our 30th anniversary in April, from April 12th, from April 13th here in Washington, D.C. You are all invited to attend on this 2-day excursions. And if you have any questions or need any additional resource, we also have our HispanicHealth.info, which is a hub that we have created for both patients and professionals for information regarding a plethora of topics. And lastly, if you have any questions, please reach out to Jason Hernandez, our program manager here at NHMA. His email is on the screen. Again, thank you so much for your guys' attendance and participation. It is greatly appreciated, and I hope you guys have a great day.